Hey guys, welcome to week 9. We're going to jump in. We have 2 PowerPoints to cover today. So let's just get the sharing of the screen started. Ignore that. I think we will start with the bloodstream infections one first that you see on the screen. So just trying to get it set up here. There we go. All right, so we're going to just get through the objectives. You can read through those later. But essentially, the first thing we're going to start with is 2 terms that you're going to hear a lot of within micro and just in lab in general, and that's a bacteremia and a septicemia. People usually use these terms pretty interchangeably. To a lot of people, they're just going to refer to them as the same thing. But technically, they do mean some slightly different things. So bacteremia is a bacterial infection of the blood. Emia in medical terminology always refers to bloodstream. So bacteremia is bacteria in the blood. Septicemia is an infection by some microorganism. It could have been bacteria, a fungus, a virus, or a parasite in the blood. And it's what they commonly nickname blood poisoning. So not that it's like a toxin in your, well, bacteria release toxins, but it's not like you have a chemical in your blood. It's you have one of the 4 microorganisms infecting the bloodstream. So that's technically the difference between a bacteremia versus a septicemia. Again, most of the time when we talk about septicemia, we usually are referring to the bacterial infection in the blood. And of course, these are very, very serious infections. Blood obviously goes throughout your body, so you're thinking of an all-over infection throughout the body, very fatal to patients, especially if they're immunosuppressed, but even to healthier patients, it's very severe, something that we need to look and work up as soon as we can. All right, so bacteria we find commonly isolated from blood. You can see it's a huge list. When you read through this list, most of these are pretty much always pathogens. They're things we talked about before with lots of stuff, especially the first 2, Staph aureus, E. coli. Oh my gosh, those things go with so many things. So you can look through, I mean, basically what I always say to people is that any bacteria really can cause a septicemia, can cause a bacteremia. If it has the opportunity and it gets enough chance, any bacteria really could do this. It's just that we have more commonly seen organisms than others, but really almost anything can result in it. Now, there is fungi that can infect the bloodstream, and that would be particularly Candida albicans. Remember, that is a yeast. And then there's another one called Malassezia furfur. That's another yeast. That's particularly isolated from neonates. Both of these are infections that would cause a septicemia. And parasites, Plasmodium, of course, that's malaria. Loa loa, Wucheria, Brugia malaria. We've talked about all these in our parasite chapter way back in the beginning of this quarter. All of these are found in the blood. Toxoplasma gondii, that's the kitty litter one, why pregnant women can't clean cat litter. Babesia, we talked about that in hematology. Trypanosoma, that was the one with Trypanosoma cruzi and then Trypanosoma brucei. Those are definitely also bloodstream. Viruses, Epstein-Barr virus, the main cause of that would be infectious mono. So it kind of stimulates and triggers the lymphocytes to become really reactive in that. Cytomegalovirus, and then definitely HIV. So these are all commonly affecting the blood. All right, so as far as detection goes, especially when we're considering bacteria, detecting bacteria within the bloodstream, we would do blood culture collection. So for those that have had phlebotomy, you probably have learned about blood cultures. So blood cultures basically resemble like the old-fashioned pop bottles. When you think of like a glass pop bottle, like a Coke, an old Coke, that's like a blood culture bottle. Kind of looks similar to it, not like perfectly, but you get the idea. So they're larger containers. They're not just like a tube. And inside those bottles are SPS anticoagulant. Now I'm going to have those on another slide here listed, so just hang on to that. But basically, we always collect blood cultures first. So whenever there's blood cultures ordered, they always go in the order of draw number 1. That's what we consider our sterile tubes, because we want to make sure that we really cleanse the site well, that we want to get rid of any chance of normal flora bacteria. We don't want to contaminate our blood culture bottles with just normal flora off the skin. If we're going to collect this, we want to make sure that we truly detect what's causing the bacteremia and have a chance of growing a pathogen and not contamination. So that's first and foremost, very good cleansing when it comes to blood cultures. So typically it's a double cleanse kind of situation. You might wipe off the patient with an alcohol pad like normal and then go in with iodine or chlorhexidine. It's just whatever your lab uses. There might be other stuff out there too. But you're going in with extra cleansing, not just the alcohol pad step. And then while that's drying, you do it in concentric circles just like always. And then while that's drying, you're also wiping off the tops of the blood culture bottles with an alcohol wipe. And so all of this is done together in the hopes that you're eliminating the normal flora contamination. Typically, I draw blood cultures with a butterfly needle hooked up to a vacutainer. I find that's easiest because you have some maneuvering room with the butterfly tubing. Some places will just draw like a syringe and get the right amount and then inject it in there. Either way, you're still cleansing just the same as you normally would. As far as the volume goes, because these are larger bottles, we need quite a bit more blood than we would if it's just a tube. So for adults, we need about 10 to 20 milliliters of blood per set. So blood cultures are always ordered in sets. There's 2 bottles. There's an aerobic bottle and an anaerobic bottle. And so we're putting 5 to 10 milliliters in each bottle. So if you put 5 in one, 5 in the other, that makes a total of 10 mils. Or you can put 10 mils in one and 10 mils in the other, 20 mils. You get the gist. So up to 20 mils of blood is what we need. So you're putting 5 to 10 in each. There will be a little label with little marks on the side. You can kind of, what we always do is we mark where the anticoagulant is, the liquid stops on that with the marker. And then up from that, you go 5 milliliters at least mark up, and then that's where you need to at least get a fill. So that's kind of how you do it. When you see it in person, it'll make more sense. But just know 10 to 20 mils of blood per culture set. Now, we do recognize that children don't have as much blood to give. We have to be aware of their blood volume is lesser. So in that case, we do have pediatric blood culture bottles. Typically, there's just 1 in a set for that. They don't have 2, they just have 1. And you can draw around 1 to 5 mils of blood into that pediatric bottle. I typically reference 1 to 3. So if you ever see it written in any of my stuff, 1 to 3 mils, that's right. That's just because that's what I always say. All right, so there's what it looks like. Those bottles in the back are the blood culture bottles. They kind of resemble those like old-fashioned Coke bottles, I think. So again, they always occur in a set. You always have an anaerobic and an aerobic bottle. The pediatric set, again, is just 1 bottle. Now, I will say this. Ideally, you always want to collect the blood culture set bottles on adults. But if you were to stumble across a really, really difficult draw, and some of those people just have horrible veins, and you absolutely need a blood culture, and we're looking for a lot of blood here, not just a little bit, but a lot. Then you sometimes can draw into a pediatric bottle and do the 1 to 3. If you have such a hard draw that you're not going to get 10 to 20 mils for the blood culture set, you may put a pediatric on in that case, but just try your best to always get the adult blood culture sets for adults. But again, if you stumble across a really difficult draw, you have to do what you have to do. All right, so the number of sets. Doctors will tell you how many sets that they want ordered. So you might get an order of blood cultures times 2. What that means is they want 2 sets of blood cultures drawn. Or they may say just blood cultures times 1 or blood cultures times 3. So they can order up to typically 3 sets is what they do. And so there is a special way that you collect this. You're not going to go and take all 6 to 8 tubes in at once, or whatever it might be, 1, 2, 3, 4 to 6 tubes in at once. I can't count. You're going to do it in timed intervals. So if you have a blood culture order times 2, you know that means 2 sets of blood cultures, which equals 4 bottles, because there's 2 bottles in a set. So you'll draw the first set, the first 2 bottles, like you would, and on there you're going to write where you drew them from. You're going to say right antecubital, or left hand, something like that. And then you're going to time it. About 15 minutes later, you're going to go and collect the next set, and you're going to take it from a different spot. So if you collect it from the right antecubital the first time, then go to the left arm and collect from there the second time for the second set. So that's really crucial to make sure that you have the 15 minutes between each and to make sure you're drawing in a different spot. And the reason that we order different sets of cultures and do it this way is to try to increase the sensitivity of detecting bacteria that might be present. Okay, so here's the additive that's in the blood culture bottle. Again, SPS. It's an anticoagulant. It just makes sure the blood stays liquid. We can't really work with clotted samples. So it's just going to make sure the blood stays liquid. It's in there. These little these little bottles go in blood culture machines. You basically will stick them in a blood culture machine, and they're going to keep them in there nice and toasty, incubated at 37 degrees, and they're continuously scanning them for bacterial growth. And we keep them up to 7 days. So we're going to keep these blood cultures with the SPS in them up to 7 days. So that machine is continuously scanning for bacterial growth. And the way that it does that is it's usually detecting CO2 development, carbon dioxide, by the bacteria. So just to note though, the SPS does cause some havoc with a few bacteria, specifically Peptostreptococcus anaerobius. This actually gets inhibited by SPS. So if for some reason they had a septicemia by Peptostreptococcus anaerobius, we wouldn't really be able to detect it via blood culture because the SPS can inhibit it from growing. Luckily for us, it's not really commonly seen in blood cultures. All right, so again, each blood culture set contains an aerobic bottle and an anaerobic bottle. The analyzers that you're putting in them are detecting for CO2 production by the bacteria. So they're continuously scanning it. It's usually like a spectrophotometry deal and a fluorescence sensor kind of thing. So continuously scanning. The minute it detects the CO2 production, it will sound an alarm. When you hear that beeping, that's your time to look up which bottle it was, take it out, and then we work up the bottle. Let's grow out what bacteria is there and identify it. And so that's what we're doing on the rest of these slides. Just to note, again, we're keeping it 7 days. At 2 days, if it hasn't beeped out as positive, we'll tell the physician, oh, still negative, we're continuing to hold. You know, there's some language that they use. At 7 days, we issue the final report of the blood cultures were negative, and then we just toss the bottles away. Some labs might tell you to keep it longer, but what I've always seen is 7 days. Again, if it does ding positive, you begin workup immediately. So what we do is, first and foremost, we gram stain the blood. And we're going to tell the physician immediately what we see in the gram stain. Because if we see gram-pox-coxy in that gram stain, the physician knows to make sure that the patient is on an antibiotic that works for gram-pox-coxy, that kind of deal. So it kind of already gives them a little insight into what antibiotic the patient should be on based on the gram stain results alone. Once we're done with the gram stain, and we get that out to them immediately and tell them there's a positive blood culture, here's the gram stain, we are going to plate it because we need to grow the sucker out. So you're just going to take a needle and syringe, get a little blood back out of the blood culture bottle. You place the drop on the microscope slide to do the gram stain, and then the other you're going to plate to everything because we don't know what's growing, so we want to make sure we can figure it out. So we're going to plate to blood agar, MacConkey, a CNA or PEA, and chocolate. If it's the anaerobic bottle that's positive, you're also going to plate to an anaerobic blood agar. Then you incubate, and we're going to begin to work up this augers the next day just like normal. So again, there is risk of contamination from the normal flora of the skin. So just keep in mind, what is normal flora on your skin? Well, a lot of coagulant staph like Staph epi is contamination or normal flora on the skin. Propionibacterium acnes is normal flora of the skin. Corynebacterium dipteroides, different bacillus species, not anthracis, obviously that's a concern. The other ones. And then just if you see a ton of organisms growing, that's contamination. Typically when people have septicemias, they have just one bacteria that's causing the problem. So it should just be one bacteria growing out. Sometimes you'll find somebody that has two bacteria causing the septicemia. That's usually a really immunosuppressed patient. So there is a chance that it could be two, but anything more than that is extremely rare. So there's not going to be a growth of a ton of different organisms here. That's going to be contamination from the draw. As far as the coagulant staph goes, which commonly we're talking about Staph epidermidis. Now, there is possibility that Staph epidermidis is causing the disease. We saw it mentioned back on the pathogen side as one of the possibilities that causes septicemias, but it's also known as a contamination. So you have to consider how many bottles did it grow in. If you drew 2 sets, which is 4 bottles, and Staph epi only showed up positive in one of those bottles, it's probably contamination. If staph epi showed up positive in 3 out of the 4, then it's probably a pathogen. It probably is causing the infection. So keep that in mind. All right, so here's how we know it's a pathogen. Again, growing in several of the bottles. And when you do isolate out and you figured out if it's strep pneumo, strep pyogenes, any of the Enterobacteriaceae or Anner, we're definitely taking that seriously, for sure. Okay, so that's bloodstream infections. I think the biggest thing that came out of there is the blood culture stuff, understanding how to collect it, cleansing is super important, you know, what goes into the sets, how to time them, that kind of thing. All right, so now let's get into our second PowerPoint, which is infections of the central nervous system. Okay, so your nervous system is going to consist of your brain and spinal cord. They have 2 protective coverings. Your outer covering is the bone, the inner covering is the meninges. And then, of course, you have fluid, cerebrospinal fluid, that helps cushion, protect all of this. It will envelope the brain and spinal cord. It also carries different metabolites, nutrients it needs, and then it carries out tissue waste, or cleanses the tissue of waste, I should say. So lots of good stuff there. Here's a nice little picture of everything. I'm not going to touch on anatomy. This is just review. But we do want to learn the diseases of the central nervous system. So probably first thing that pops in your head when you think of a central nervous system disease is meningitis. So infection of those meninges. You can have what we call purulent or aseptic meningitis. So purulent is going to be a very acute inflammatory meningitis. It has the classic meningitis signs of fever, stiff neck. And just so you know, that stiff neck should be really stiff neck, not just, oh, it aches a little. No, we're talking stiff neck. Headache, nausea, vomiting, all of that stuff is normal symptoms of meningitis. Huge numbers of neutrophils, of PMNs, which are neutrophils. So you're going to see a very bacterial purulent meningitis here. So anytime you have elevated levels of neutrophils, it's usually signaling a bacterial infection. So when we see bacterial infection, we're going to see a lowered amount of glucose. And that's because bacteria eat the glucose for energy. They want that sugar for energy. So we lower the amount of glucose in the CF, in their cerebrospinal fluid, and then you'll see the protein levels increase. So bacteria that are nasty little culprits of bacterial meningitis, these should all be familiar to you. Of course, we have Haemophilus influenzae type B. That was the most common bacterial meningitis in children. Now that we have that HIV vaccination that all children should be getting, not everybody gets it, but you know what I mean, that kind of has reduced it down to almost nothing. So I don't know if that's the most common anymore. It might still be, but it used to be way more prevalent than it is now. Now that they have the vaccine, it's kind of wiped it out. Neisseria meningitidis is still a big one. That one's especially a concern in the older teens when they go to live in dorms and the close sharing of quarters. We hear meningitis there. Strep pneumoniae, they have a vaccine for that, especially older adults get that vaccine, like 60s. I have it, though, already because I'm asthmatic, and so they will give it to people at young ages that have asthma because our lungs are already prone to, like, pneumonias and things like that. But just know strep pneumonia also causes meningitis, not just pneumonia. Listeria monocytogenes, that's the one that you can get it by eating soft cheeses, deli meats when you're pregnant, and then it gets passed to your newborn as neonatal meningitis. E. coli, other grass. Let's see. Oh, strep A. galactiae. That's also another neonatal meningitis. So we've learned all of these. So these should all be very familiar to you as causing meningitis. Okay, so the aseptic meningitis is a viral type of meningitis typically. So you will see an increase of lymphocytes here, fever, headache, stiff neck, same kind of symptoms, but more of the increase in lymphocytes. The neutrophils are going to stay pretty normal, if not lower. Sometimes you might see syphilis cause this type as well. Syphilis is a spirochete, but it can show more signs of this than others. There is the tertiary stage of syphilis really affects the CNS, so it might affect it like this. But usually aseptic is a viral type meningitis. All right, other diseases, we have encephalitis, which is inflammation of the brain, typically due to a viral infection. Meningoencephalitis would be a meningitis with an encephalitis. Wouldn't that be fun? All right, so those viruses that cause encephalitis, your adenovirus, your mumps virus, which we have a vaccine, herpes, and then West Nile. So that's the big thing with West Nile virus, is it causes encephalitis. There's parasites, Naegleria fowleri, and acanthamoeba. We talked about these back in week 2. Naegleria was the one when they went swimming and it shot up the nose into the brain, and then they were fatal within a week. And you hear those different reports in Wisconsin, Minnesota lately. That's the guy that's causing the encephalitis, or the meningoencephalitis, I should say. Toxoplasma gondii, Entamoeba histolytica can sometimes do this. Taenia solium, we mentioned him. He's our pork tapeworm, but he also causes that disease called cysticercosis. There's a whole page on CDC that talks about that, but it does affect the brain. Brain abscess is anytime you get a collection of pus in a cavity. Typically, you're not going to see anything showing up in the CSF for this part. All right, so collection. We are typically, to screen the meningitis, especially we're collecting cerebrospinal fluid. It's done by a spinal tap. Obviously, we're not performing that. That would be done by the provider. But they're going to collect 3 or 4 tubes. Now, for those that have taken urinalysis, this should be reviewed for you. But let's remember the tubes and the order they go in. There's a very specific order that we send the tubes in because we know that it least interferes with those tests. So tube 1 always goes to chemistry. Tube 2 goes to microbiology. And the reason tube 1 goes to chemistry is if there's any contamination from normal flora, it's in tube 1, and we don't care about contamination of normal flora in tube 1. We would care about it for the microbiology culture, but that's why we put that as tube 2. Tube 3 is hematology. We're going to do the cell counts, the neutrophil, the lymphocyte, the white count. And then if you do have a tube 4, usually this is just kept for other or cytology purposes. Now, cerebrospinal fluid should typically be clear and colorless for the coloring just normally. If it's cloudy, that's going to tell you probably an infection with an increased cell content. If it's red, it's going to tell us either you have a hemorrhage or what we call a traumatic tap. When the physician did the lumbar or spinal tap, they caused some trauma upon first doing it. And so you'll see red in the first 1 or 2 tubes, and then it will clear up. Whereas if you have a hemorrhage, it would be red throughout. So traumatic tap is just going to be red in the first couple, whereas a hemorrhage would be red throughout. If it's more of a brown color, that's just telling us that's old, dry blood. Not dry, but older blood. CSF is always treated stat. We're never going to let this sit around and hang out. We are always running it right away. When you definitely gram stain it. First things first, we gram stain, and then we're going to plate it. When we look at the gram stain, of course, we're looking for bacteria, but we're also looking to see if there's neutrophils there, red cells, that kind of thing. If you do a wet prep of it without staining, you can look for like those amoebas, like entamoeba. And if you think you have Cryptococcus neoformans, you can do an India ink stain. Remember, Cryptococcus neoformans is a yeast that really affects HIV patients, especially AIDS patients. And this yeast has a capsule around it. And so as a result, when you stain with India ink will stain everything else except the Cryptococcus because of the capsule. It can't get in there. So the Cryptococcus almost looks like little halo, round little halos, because they did not take the stain. So what we plated to, blood agar, chocolate agar, definitely. We're looking for Haemophilus, Neisseria. Those are 2 of the big bad boys here. And those are fastidious. They like chocolate agar better. Thiobroth, so these are definitely going to all be plated. You could probably add a CNA if you want or something, but these are going to do what they need to do. All right, so that is it. If you guys have any questions or need anything, as always, please feel free to reach out. Otherwise, have a fabulous week.